and maybe good morning and good afternoon for those of us attending from the United States as well as Europe. I'm Jonathan from National Heart Centre Singapore, and it's my privilege today to bring to you everyone our second in the series, the CHIP series brought to you by the APSC Emerging Leaders in conjunction with the Transcontinental CHIP Case Sharing Club. And today's topic is complex left main interventions. This event is endorsed by the Singapore Cardiac Society, accredited by EBAC, and we are facilitated by a grant from Boston Scientific and ABiomed. This is a rough program that we're going to have installed today. We have two keynote lectures, one on revascularization for left main disease, and one using intravascular imaging to optimize left main PCI. And this will be followed by an interesting debate on the best strategy for distal left main bifurcation disease. There will be interactive discussions in between each of these talks. I'm privileged to have with me today Dr. Jonathan Sung from Hong Kong. He'll be my co-chair today. And we have with us an esteemed panelist, advisors, Dr. Jack Tan from National Heart Centre Singapore, Dr. Ho Lam from Tuen Mun Hospital, Hong Kong, and Dr. Jung Min Ahn from Asan Medical Centre, South Korea. The speakers will be introduced in depth later, but we have Dr. Brian Bergmark from the United States, as well as Dr. Chin Chi Yang from Singapore. And for the debate, we have Dr. Richard Chan from Malaysia and Dr. Lam Ho from Hong Kong. We have an international group of panelists with us here today. We have Dr. Vishnu Aditya from Indonesia, Dr. Yasusugo Shiono from Japan, Dr. Jayakanthan from Malaysia, and Dr. Muhammad Al Omari from Australia. Some housekeeping rules. The content of this webinar is copyrighted by the APSC, but the views and opinions expressed are those of the faculty members and do not necessarily represent those of the APSC. This webinar is live streamed via Wonder, Facebook, as well as YouTube, and CME points and a certificate of attendance will be awarded. Very importantly, if you have questions to ask, please use the Q&A button at the bottom of the screen and post them. We'll strive to answer as many questions as we can during the discussion sessions. So without further ado, I'd like to hand over to my co-chair, Jonathan Sung. John, please.
Thanks very much, Jonathan. Pleasure to welcome you all to the second event of our CHIP series. We had good feedback from our last event on mechanical support in cardiogenic shock, and hopefully this time you will all enjoy this meeting focusing on left main intervention, and hopefully you will all learn something from sharing by our experts today. So without further delay, may I introduce our keynote speaker today. We're privileged to have Dr. Brian Bergmark from Brigham Women's Hospital, who will give us a lecture on left main intervention. Dr. Bergmark is an interventional cardiologist in the complex coronary CTO program at Brigham Women's Hospital, Harvard Medical School, and an investigator at the TME study group. He received his bachelor degree from Stanford University and his MD from Harvard Medical School. Dr. Bergmark completed his residency in internal medicine, fellowship in cardiovascular medicine, and fellowship in interventional cardiology at the Brigham Women's Hospital. His research interests include acute coronary syndromes and complex coronary interventions. On a personal note, Dr. Brian Bergmark is one of my mentors and supervisors during my time in Boston, and someone I'm proud to call him a friend. And he's also someone I'm ready to tell my grandkids that I've worked with before, although I'm sure they would not believe it. So without further delay, may I pass time to Dr. Brian Bergmark for his talk.
Jonathan, thank you, and to everybody else. It's a pleasure to see you, and I count as one of the privileges in my life, the opportunity to work with you while you were in Boston and continue to collaborate. So thank you all. I am sharing the slides here. I assume somebody will speak up if you're not seeing them. So there's a lot to get through here, and so I'm going to move quickly. These are my disclosures. I know there's going to be some more talks about some of the more technical aspects of left main PCI, so I thought I would focus largely on some of the evidence base around this, and then a case at the end. that actually highlights a difficult complication that I found myself in recently and might be a topic for discussion. But to start, I thought we'd go through some of the data. This is from a meta-analysis that our group did recently. And so by way of background, we know that people with left main disease that goes unrevascularized do poorly. This is now quite dated, but this is from the VA cooperative study in the 1980s, 700 men with coronary disease in the US VA system. They were randomized to CABG or medical therapy. 91 of them were in the left main subgroup, and that was defined as a stenosis of at least 50%. You can see in the panel on the right that the people who did not get revascularized, who were managed medically, did very poorly. And this is one of the initial randomized observations indicating the importance of revascularizing patients with left main disease. In the more recent era, PCI with drug-eluting stents or CABG may be considered for the treatment of unprotected left main disease in patients with low to intermediate anatomical complexity. Data comparing these two revascularization strategies stem principally from 4 landmark trials: the TACS trial, Pre-Combat, Noble, and Excel. However, differences in trial composite endpoints and findings have led to persistent uncertainty among clinicians and practice guideline committees regarding the optimal revascularization strategy. And so ultimately that led to a collaboration to look at individual patient data from these 4 trials. So collaboration was formed among a group of independent investigators. And I should note that this group included 1 interventional cardiologist and 1 cardiac surgeon, in addition to general cardiologists and a statistician, and then the principal investigators of the 4 trials. We, as the independent investigators, created the statistical analysis plan, performed all analyses, drafted the manuscript, and had complete control over the content, and also vouched for the integrity of the analyses and the findings. We used a 1-stage meta-analytic approach on a combined data set of individual patient data supplied by each trial. The primary endpoint we chose was all-cause mortality through 5 years. And we looked at 5 secondary endpoints: cardiovascular death, spontaneous MI, procedural MI, stroke, repeat coronary revascularization. We also performed landmark analyses and supplemental analyses using 10-year mortality data where available, as well as subgroup analyses. And finally, we performed Bayesian analyses to help quantify the probability and magnitude of any difference in mortality. Shown here are the baseline characteristics for this cohort. There were 4,394 patients, and it's important to keep in mind that they had to be judged to be equally suitable candidates for PCI or CABG in order to be enrolled in any of these 4 trials. The median age was 66, about 3/4 were men, 1/4 had diabetes, a small portion had an EF less than 50%. The median syntax score was about 25. A small portion had left main only disease, whereas about half had left main plus at least 2 vessel disease. The median number of stents or conduits was 2. IVUS was used in about 2/3 of the PCIs, a LEMA in nearly all bypass surgeries, and all arterial grafting in about 1/4. And so here's the primary comparison: death through 5 years. There was no statistically significant difference: 11.2% after PCI, 10.2% after CABG, hazard ratio of 1.10, p-value of 0.33. Getting into the Bayesian analysis, the vertical dotted line here indicates no difference in total mortality between PCI and CABG. Anything to the right indicates higher mortality after PCI. You can see that the curve is overall shifted to the right. And to quantify that, there was an 86% probability that mortality was greater with PCI than CABG, so any mortality difference greater than 0. But what about higher thresholds that might be of clinical relevance? So there was a 49% probability that the mortality difference was at least 1% over 5 years. So that would be 0.2% per year. And there was a 5% probability that the mortality difference was at least 2.5% over 5 years. So that'd be 0.5% per year. So from the Bayesian analysis, we concluded that mortality is probably higher with PCI over this time period, but the absolute risk difference is more likely than not less than 0.2% per year. What about cardiovascular, non-cardiovascular mortality? No significant difference in either of these. You can see the incidence curve here for cardiovascular mortality out to 5 years, an absolute difference of 0.4%, not statistically significant, less than 0.1% per year. We had 2 trials with 10-year mortality data, TACS and pre-combat. You can see a mortality rate of 22.1% after CABG, 21.6% after PCI, out to 10 years, hazard ratio of 0.96. What about subgroups? You have to be very careful in looking at subgroups. We're not adjusting for multiple testing here, but there are a few of particular clinical interest. We're analyzing diabetes status right now. One of our excellent fellows, PK, presented acute coronary syndrome data at TCT this year. And then we've also looked at syntax score, which, given our prior understanding of the importance of coronary anatomical complexity, we think there's enough a priori understanding of this that it's worth looking into a bit more. So we did actually look at syntax score continuously, and the hazard ratio for cardiovascular death is shown on the y-axis. And you can see, while the interaction is not statistically significant, CABG appears to be favored starting at a syntax score of about 33. There's really no difference. It's right at 1 until a syntax score of about 33. And then it really does look like CABG is favored at the higher syntax scores. What about other trial endpoints? MI and repeat revascularization. Sorry, the slides are getting a little slow here. Spontaneous MI is unequivocally higher after PCI, 6.2 versus 2.6%. Repeat revascularization also clearly higher after PCI, 18.3 versus 10.7%. Procedural MI is a complicated topic, and we're not going to get into it right now. Shown here on the left are the results comparing PCI versus CABG using each of the trial's own definition of procedural MI, which tended to use CKMB and high biomarker thresholds. Procedural MI was less common after PCI than CABG with these definitions. In 2 trials, Syntax and Excel, we had procedural MI data using the universal definition of MI, which favors troponin and applies different thresholds for PCI and CABG. Here, there was no statistically significant difference between PCI and CABG. Stroke, over 5 years, no statistically significant difference, but there was actually a violation of the proportional hazards assumption. And if you look at just the first year, where I think a reasonable person would expect a difference to manifest, there were fewer strokes after PCI, hazard ratio of 0.37, and then no difference beyond the first year between PCI and CABG. So lower rate of early stroke with PCI. So to summarize the meta-analysis, comparing PCI with drug-eluting stents versus CABG in patients with left main coronary disease, a median syntax score of 25 and deemed equally suitable candidates for either approach, there was no statistically significant difference in survival at 5 years and also at 10 years. A Bayesian approach suggested a difference favoring CABG probably exists, and that it is more likely than not less than 0.2% per year in magnitude. And a possible cardiovascular mortality benefit of CABG appeared confined to patients with high syntax scores. CABG clearly reduces spontaneous MI and repeat revascularization, and PCI reduces early stroke. The difference in risk of procedural MI depends on the definition used. And so how do we put this into a broader context? Of course, these data look at a few endpoints and need to be taken into account in the context of the non-coronary anatomy, local expertise, patient preferences, resource utilization, comorbidities, et cetera. And so where do we go from here? It's important to keep in mind that these findings apply to a subset of patients with left main disease, where equivalent revascularization was considered possible, and largely low to intermediate anatomical complexity and pretty limited comorbidities. A large trial with the latest surgical and PCI techniques would be nice, And so a lot of people say, well, what if everybody used imaging and et cetera? But one, it would be difficult to achieve adequate power for a mortality difference. This would be a large and long trial. And there will always be a tension between long-term follow-up and state-of-the-art revas. And I would say, actually, I think everybody on this call is involved in these conversations. And I think we all know that refining the mortality difference for a point estimate is really not the major issue here. That when we have these conversations, patients bring to us priorities that are not captured by these trials. And the issue is, how do we balance patient values and preferences with the small number of hard outcomes for which we have data? And we don't really have information for a lot of the things patients really care about, like what is the likelihood of kidney injury or requiring dialysis, et cetera, for the left main cohort specifically. We do have recent trial data comparing PCI versus CABG in complex coronary disease from FAME-3. There were 1,500 patients with 3-vessel disease randomized to FFR, guided PCI or CABG. So not exactly this cohort, but they wisely looked at a number of other post-procedural outcomes that are quite important and not captured in these other trials. So bleeding significantly higher after CABG, acute kidney injury more frequent after CABG, atrial fibrillation or clinically significant arrhythmia, and rehospitalization within 13 days, nearly twice as common. And so these are the kinds of endpoints that really do impact somebody's experience. How does this compare to a future revascularization event? That's really hard to know and important in our conversations with these patients. So how does this play out in practice? So I want to show a couple cases here. So the first is a 70-year-old woman with an NSTEMI, no diabetes, normal EF, and mild COPD. And this is actually one of the few cases here of the three I'm going to show that really falls within the paradigm of the data I just showed. She overall had a low syntax score, low surgical risk. And I think this is really someone where you can say, look, there's an osteo left main lesion. Let's have a conversation about how to approach it here. No meaningful difference in mortality, trading off lower procedural risk with PCI, maybe longer term likelihood of a revascularization or spontaneous MI in the future. At one end of the spectrum here is a young patient, 59, diabetes, mildly reduced EF, no major comorbidities, high syntax score, low surgical risk. And I think this is not captured in the trial data well. I think most people would look at this and say, yeah, if he's a good surgical candidate, this guy should probably get CABG. And that's what's shown in the registries from the trials of PCI versus CABG. For people where there was not equipoise, they tended to be younger with high anatomical complexity. At the other end of the spectrum are the elderly patients with comorbidities, often with high anatomical complexity as well, but who are not considered surgical candidates. And these are the patients that Jonathan and I spent a lot of time stenting when he was here in Boston, and are really the bulk of our left main interventions. And these are often very high-risk procedures. And so this is a recent example, 82-year-old woman. She had an NSTEMI, heart failure. She'd been turned down for CABG and PCI at another hospital, had an EF of 25%. And these are the films from the other hospital. Non-selective because of this osteo left main disease. It's pretty hard to even know what's going on here. Here's another picture. You know, honestly, I really wasn't sure what we were dealing with here, but, you know, so we had a conversation with the patient and her family, and, you know, there was no clear medical management strategy here, and decided to proceed with PCI. And so this brings up a few issues I'll touch on briefly, including, as I mentioned, a complication that I hope most of you never deal with, but is an important one to keep in mind. So we decided we were going to use Impella support up front. Excuse me. Single access techniques, so put in a 7 French Terumo destination sheath through the Impella introducer sheath. We assumed we were going to use the DK crush approach and IVUS guidance, though we didn't really know what we were getting ourselves into. Here we just kind of put down a wire to stabilize the guide a little bit and take a picture. And it's obviously quite a mess here. The left main is a mess, the LAD into the circumflex as well. So we moved ahead with our plan. And here we're just ballooning, making sure things are expanding nicely, which they were despite the calcium. We stented the circumflex, crushed it, recrossed, kissed, LAD. So this was our final kiss. So we thought we were going to do this, pot, IVUS, make sure everything's okay and be done. And this is what we saw. And so this is not a fortunate situation. You know, the perforation appears to be most evident in the proximal LAD, but there's obviously something going on here in the ostial left main as well. And so I was concerned that this process started in the left main and that simply putting a papyrus-covered stent in the LAD was not going to deal with this. But nonetheless, we put a balloon up in the LAD to see if we could cover this. And this is clearly not stopping the extravasation. So simply dealing with the LAD here is not going to solve the problem. And so, you know, there could be a conversation about how to approach this. What we decided to do was to put a covered stent from the left main across the LAD, knowing that we were then going to jail the circumflex and need to fenestrate the papyrus, re-enter the circumflex, and there was going to be a period here of ischemia. But that's why we had the impella in. And so we proceeded. Here we took a puff, the papyrus did cover. So we've dealt with the perforation, but now we have no circumflex. And so you can see the heart is not moving very much at the moment. And so then here's a Supercross 120 angled microcatheter with a Convianza Pro 12. And you can actually see in the guide, we have a 3.0 balloon with saline, so you don't see it inflated, but we're actually trapping the Supercross in the guide because it was just kicking back. And then with that support, we could get this Confianza Pro 12 to puncture across the papyrus and into the circumflex. And then took out the Supercross, used a Turnpike LP to cross and exchange for a workhorse wire. And then from there, ballooned, kissed, potted, IVUS, et cetera. And so there we were at the final result of the PCI. So in conclusion, left main coronary artery disease is associated with high mortality. Current revascularization recommendations are informed by 4 randomized trials. Differences in endpoints and interpretation have led to standstill in the field. In an individual patient data meta-analysis from the Syntax, Pre-Combat, Noble, and Excel trials, a mortality difference favoring CABG probably exists, though it is more likely than not less than 0.2% per year. It is likely confined to high anatomical complexity. Higher rates of MI and repeat revascularization are seen after PCI, and a higher rate of stroke in the first year after CABG. And integrating these findings into patient-centered decision-making is the central challenge moving forward. Specifically with respect to left main PCI, successful PCI requires careful planning, including optimization of comorbidities, the need for MCS, vascular access considerations, PCI technique, including equipment selection, intracoronary imaging, calcium modification, bifurcation approach, and then anticipation and recognition of complications. So thank you. I appreciate again the opportunity to be here and look forward to the rest of the discussion.
Thank you, Dr. Bergman. It was a wonderful lecture. It's a good cover of not just the literature, but 3 very distinct cases to drive home the point. Could we have the main screen with? Yeah. Okay, I've got some questions I'd like to ask, both related to decision for revascularization of left main disease and maybe specific to the cases as well. Maybe we start off with consideration, between bypass as well as PCI for left main disease. It'll be really interesting to hear the variability in practices around the region. Maybe first up, I could ask Dr. Ahn, from Korea. If you have a patient with left main disease, it's a bit older, like more like the surgical reject cases, maybe you're 70 to 80 years old, ejection fraction is a bit low, how does the discussion go between PCI versus CABG at your center?
Thank you very much. I think that your question is very important. This is patient subset is very important. First of all, thank you very much for very nice presentation, Dr. Brian. So I think that it is not the bypass surgery versus the PCI is not a debate anymore based on the Brian's great works. The independent individual patient meta-analysis show that no mortality difference between the bypass surgery versus PCI regarding the mortality. So we can do both PCI versus bypass surgery. The next issue, if you want to do PCI, the next issue would be we can do good PCI. So if we saw the patient, we have to do good procedure. I think why PCI increase mortality, I think that is due to the physicians not to do good PCI. Based on the US data, the experience of left main PCI is still very rare. The per hospital, only less than 10 cases per year, they did the left main PCI. This so any patients cannot do the enough experience for the left main PCI. They didn't have any enough experience to overcome PCI related complications. That is very important. That is very important to the situation nowadays. So for this patient, unfortunately, we don't have the impeller. So 25% ejection fraction, very old patient. Based on my IVR evaluation, left main PCI, we can do I think we can do the left main PCI, but be very cautious. If we have an impeller, I'd like to support the impeller, similar to the Brian, but we don't have. Just I keep the small 5 French sheaths for the left for the immediate ECMO support. In case of emergency situation, I like to do the 2-stent technique because there is tight stenosis and the LAD and circumflex ostium based on the angiogram. But one of my comment would be the 82-year-old ejection fraction is very low. I don't like to do the best, get the best result to save the patient's life. So the Brian told us that did procedure according to the IVR's guidance, but the left main stent size looks bigger based on my IVR evaluation. So I like to select the smaller size of a stent, then just to make antegrade flow to the LAD and circumflex using 2-stent technique. Thank you.
I think these were very important points raised. For every left main procedure that we do, we need really meticulous planning and really very careful technique, and we should not take each case lightly. Maybe I'd like to ask one of our younger interventionists, Vishnu, like in Indonesia, right? How do you guys select patients for bypass versus PCI? Any tips or tricks to share with everyone?
Hey, yeah, thanks for the question. So I think it's the same with everybody that first we have to, well, Brian also has already stated that sometimes there's a small factor that we consider that can change everything. For example, probably even though we already decided what's the best for the patient, if the patient preference is not having a surgery, then it's done. Or for example, if the insurance doesn't cover the bypass or doesn't cover more than putting 3 stents and the patient will need more, than it's done also. So it's all that small details that even though it's very small, but it can be a very decisive factor for this decision. And all we can do is make the best recommendation medically. But whether the patient will have a surgery or PCI, it's always up to the patient, I think. And it's also down to the technical considerations and the social situations. Well, in terms of the cases medically, Well, I think Brian's presentation already excellent. I also made a similar presentation on the topic, and I also used his data meta-analysis. So I think we already agree that if we do everything the same for all population, then roughly PCI and bypass in general population, syntax round 24, there will be no significant difference. But there are some patients technically that are better to be done PCR or bypass. For example, if the proximal is really bad, but the distal is really good, then it will be complex, technically complex to do PCI, but it will be a simple case for bypass. And on the other side, there will be some left main cases that will be very simple to do PCI, but they have a very bad distal and it will be bad for bypass. Then, in my opinion, we should always choose a simpler one. If the patient is technically simpler to have a PCI, then PCI. If it's technically simpler to have a bypass, then bypass. So that will be my 2 cents. Thank you.
That's a very important point. Sometimes, if bypass is the better option, but the patients are just intrinsically just afraid. Sometimes having a talk to an interventionist who explains that, PCI procedure is not necessarily simpler, may actually help to sway the patient towards bypass. John, do you have a question as well? Comment?
Yeah, thanks. Thanks very much, Brian. I think that was an amazing talk. So remember you shared a paper on like opening up this circumflex after implanting a cover stand while I was in Boston. So I didn't know you actually did one case like this, but it's amazing. So my question here is, so we all understand like for complex left main disease, it's probably worth a discussion on cabbage, as your meta-analysis or various other literature have shown the superiority of cabbage. But on the other end of the spectrum, if we're talking about like proximal or mid left main disease without involving the bifurcation, like I felt like it's hard to actually think of a cabbage in this scenario when I could just deal with the lesion with a single stand optimized by imaging. So is there some sort of like this subgroup analysis in your meta-analysis that focus on these type of patients where it's actually pretty straightforward for PCI to happen? Like, is there really like a need to still talk about the cabbage, or we should actually just stent it in these kind of patients?
Yeah, I think it brings up a couple points that are good ones. One is just what do the trial data show, but 2, practically, how do you approach this in discussions with the referring physician, with the patient and their family, et cetera? I think the data are tough because, in the end, the trial populations are defined by being considered equally revascularizable. We are looking at the subgroup of people with distal left main disease versus others. But in the end, we're going to be left with a relatively small group in a artificial population. But I think practically, when we all see these patients, we think probably in our gut, PCI makes sense. This is not complicated. It happens to be the left main, sure, but this is a straightforward stent procedure. And so in those situations, obviously, if it's an emergency and then they're in shock, whatever, we're going to stent it. But for somebody who's stable, I do tend to at least have a conversation. But in this type of conversation, I tend to guide the patient much more toward PCI than I would in a situation where I'm more ambivalent, where I might say, look, I think this would make sense for us to stent it. We can have you out of here in the same day. There is still a higher risk that you are back for another future procedure, but you avoid a bypass surgery. And it's a bit more of heavy-handed, or I give my specific opinion more so than I would in a situation where I'm truly in equipoise. But I do tend to at least have a conversation for the reason that, after the fact, somebody might say, well, why did you stent that left main without talking about it? If there is a complication, there's just a higher risk that something bad happens. And I think it's preferable to have had that conversation ahead of time if if there's an opportunity to do so.
Thanks. I think that makes sense. Thanks.
Yeah, so I think that's a very important learning point to all of us listening in, that discussion with the patient and the opportunity to make that decision rather than rushing into something if it's not acute is really, really important. So we need to move on. It's been a great discussion so far, and we can run back to some of these pointers later on. Next up, we have another very interesting lecture by Dr. Chin Chi Yang on using IVUS to guide our left main interventions. Chi Yang is a good friend and colleague of mine, together at National Heart Centre, Singapore. He's a very passionate guy about imaging. He spent 1 year in Columbia University and with CRF doing intravascular imaging in New York. And we look forward to learning from you, Chi Yang.
Great, thanks. Thanks, Jonathan, and thanks to the organizers for the opportunity to speak today. So the topic I was given was to try and speak about intravascular imaging to optimize left main intervention. 15 minutes is obviously not doing any justice to the topic, so I'll try and focus on certain bits which I think may be more useful. Okay, so I'd like to structure the talk on the moments perhaps, or the times during PCI that you might consider or where we should consider using imaging. And I think obviously we can split these 3 moments into the pre-PCI planning. So this would be before obviously we decide that PCI is required for the left main. And I think one of the important points to take away from this is that as opposed to non-left main lesions, the IVUS minimum lumen area does have a good correlation with FFR in left main lesions. Okay, so this would be one time to think of whether or not imaging might be useful before we embark on PCI. And obviously, if once we've decided that we do want or do need to do PCI on the left main, then obviously during PCI, imaging can help us with lesion preparation, can help us choose the correct devices or the size the devices appropriately, and obviously it can help us optimize our results. And obviously, finally, post PCI, what is acceptable? I'll show you some data on what is deemed to be good enough results, perhaps, to try and reduce the risk of recurrent events thereafter. Okay, so intravascular imaging pre-PCI. Does imaging really improve outcomes? And can imaging tell me whether or not a lesion in the left main needs to be treated? I think we should be quite familiar with the ULTIMATE and IVUS XPL studies, which show, which are randomized controlled trials, obviously, that show that there is a reduction in event rate when patients undergo IVUS-guided PCI versus angiographic guided PCI alone. And these results or these outcomes extend to 3 and 5 years. When even in pooled analyses from the data obtained from these 2 trials, we have obviously the same signal, and in fact, there's even a signal towards improvement or a reduction in death, in cardiac death at 3 years when we use IVUS versus angio alone to guide our PCI. Obviously, in these trials, this is not left main exclusive. So do we have any randomized controlled trials in left main PCI alone? The short answer is no. Most of what we have is observational data. So these are just 3 observational kind of studies, but by and large, they all show a trend towards a reduction in events, including death, revascularization, major adverse cardiac events after when we use IVUS or when we use imaging to guide our PCI in the left main versus when we do not. So overall, there is a signal that obviously with imaging, we can improve outcomes after PCI. Now, can IVUS or the minimum luminal area derived from IVUS help us predict whether a lesion is significant or not? In non-left main lesions, this is problematic. You can see these are historical, very long ago kind of trials. looking at different cutoffs for the MLA. You can see there's a big range here. And by and large, the accuracy for predicting whether or not a particular minimum luminal area is causing hemodynamic significance is quite poor. But somehow in the left main, this is different. And there's quite a good correlation between left main minimum luminal areas with physiological indices such as FFR. In this seminal trial by Jasti from 2004, which is where we get a lot of our, where we use the 6 millimeter square cutoff. In this trial, they showed that an IVUS MLA of 5.9 millimeters square corresponds to an FFR of 0.75. And this data was prospectively validated in the LITRO study, where patients with IVUS MLA of more than 6 millimeters square were deferred from revascularization, and those with MLA of less than 6 millimeters square were revascularized. And the outcomes between the two groups was very similar. So it was the conclusion, therefore, was that if you have an IVUS minimum luminal area of more than 6 millimeters square, it is safe to defer revascularization. Of course, we also have data from Asia, and Dr. Ahn, who's with us here today, will be familiar with these data. This is from his center, Asan Medical Center in Seoul, Korea, where they proposed that the minimum luminal area of 4.8 millimeters square was appropriate for an Asian population. So 4.8 millimeters square minimum luminal area in the left main corresponded to an FFR of 0.8. If you wanted to be even more precise or have an even greater predictive value, then IVUS MLA of 4.1 millimeters square corresponded to an FFR of 0.75. Okay, so I'm just going to show a very short case here on how we can use these numbers to assess a particular left main. This is a patient of mine from a few years ago, 67-year-old man, previous PCI to the LAD. He now presented with unstable angina to a different hospital. So he had his angiogram done in another hospital, and they reported the angiogram as showing 80% left main coronary artery stenosis. He was referred to my center for bypass because the other center did not have the facility for bypass. So he was transferred over, and the patient ultimately declined bypass surgery, and he was listed for PCI to the left main. So this was the angiogram that we performed in our center. On the left, the rotational angiogram. The left main is not very clearly seen, some haziness, as you can see here in the caudal view. So angiographically, really not very clear. So I proceeded to perform IVUS interrogation on the patient first from the LAD and then from the circumflex. This is the pullback from proximal LAD and proximal circumflex, but just to summarize, I found that the minimum luminal area in the left main was actually not that small. It was 6 millimeters square in the pullback from the circumflex, about similar from the LAD. And so this was, above the cutoff that we have heard earlier. So, this is a patient that was already primed for bypass and now was primed for left main stenting. So rather than just rely on IVUS, I wanted to further confirm this with physiology. He had a further lesion in the LAD where the minimum luminal area was 2.1 millimeters square, just at the distal edge of his previous stent. So I thought that would confound any FFR assessment of the left main. So I went ahead to treat that with another stent. And then after this, I performed the FFR assessment both in the left LAD as well as the circumflex, and we found that the FFR was negative in both branches. And so we deferred PCI to the left main. And so this patient, instead of having a bypass operation or a left main stent, instead just had a stent to his LAD. So I think intravascular imaging before we embark on PCI, just thinking about intravascular imaging is quite important. If we want to use it as a tool to help us decide whether or not the lesion is severe enough to treat. And if we are going to treat a particular lesion in the left main, then I think we really should be thinking about how to optimize best, give the patient the best result as possible. And I think imaging would be very important in this case. All right, so intravascular imaging during PCI, we can use this to assess lesion characteristics, to better prepare our lesion. We can use it to guide our strategy, 1 stent versus 2 stent. We can use it to size our devices, both in terms of diameter as well as length, to prevent geographical miss, and also to prevent under-expansion. So I'll show you another case. This is a 77-year-old man. He's got a lot of risk factors. He presented with non-ST elevation MI and a heart failure. His echo LVEF was 35%. And on angiogram, he had calcific 3-vessel disease. He was referred for bypass. Not surprisingly, he was deemed too high risk by the surgeons because of a calcified aorta, amongst other things. And so he was planned for multivessel PCI. So this is his angiogram of the left. Hope we can appreciate that there is some calcification in the left main to LED. The distal left main also looks tight. Yep, so this is a patient with left main bifurcation disease, heavily calcified vessels. I, definitely needed to use imaging. I decided to use IVUS in this case. In terms of lesion preparation, can I get away with just high pressure balloon dilatation? Do I need atherectomy? The side branches, the circ wasn't very big. The very high diagonal was a much bigger vessel branch, and it was very close to the circ. So I kind of treated the high diagonal, as the main kind of branch to the lateral walls. So whether or not 2 stent or provisional, I used I allowed imaging to further guide me. So this imaging from the proximal LAD. At this point, we see some eccentric calcification. This is the diagonal, the high diagonal coming in. Get a bit of signal dropout. But we can see the lumen is very tight here. So that's the circumflex coming in. So we're in the distal left main now. It's still very tight. There's concentric calcification here. And because, I saw what I saw here, concentric calcification, distal left main extending a little bit back. My strategy was for some debulking. It's just a summary of the IVUS findings. So I used a 1.5 and a 1.75 millimeter burr to create a path. This was the angiogram on the right after rotational atherectomy. And then, this is just some post-rota IVUS images, pre and post, pre on the top row and post at the bottom row. You can see that there's some luminal gain, as well as this looks like the rota has bitten a chunk of the calcium here in the column A. Column B, you should see some luminal gain. And in column C, again, we see some luminal gain with maybe a calcium crack as well. Thereafter, based on IVUS, I decided that the diagonal 1 ostium was also significantly diseased enough that I needed a 2-stent technique. Tried to protect the circ, but I was unsuccessful. So first stent to the diagonal, and stent left main to LED, and then a final kiss. So that was just to show that the use of IVUS during the PCI guided the way I performed the PCI. The fact that I needed or decided to have atherectomy versus just balloon dilatation, and also in terms of the stent sizes, lengths, as well as diameters. Now, finally, intravascular imaging post-PCI. How do we decide when it's enough in terms of PCI? What is an adequate enough minimum stent area? What is adequate enough expansion or apposition? And of course, we can use imaging post-PCI to look for complications such as dissections or hematoma, see if our ostial positioning of the left main stent is adequate, whether we're sticking out too much into the aorta, and look for any disruption of the stent struts. So again, this is data from the Asan Center where they studied 400 patients who underwent left main bifurcation stenting, and they found that these cutoff values for minimum stent area post PCI were kind of predictive for the risk of developing in-stent restenosis at about 9 months. So if you were able to achieve a circumflex, osteal circumflex, a minimum stent area of more than 5 millimeters square, or an LED minimum stent area of more than 6.3, polygon of confluence, which is this area here, just before the left main of more than 7.2, or a left main area of more than 8.2, then your risk of having in-stent restenosis was lower than if you were not able to manage these numbers. So this is, I mean, a lot of people like this study because the numbers are easy to remember, 5, 6, 7, and 8. So this is quite a good general kind of guide to deciding whether or not your PCI is adequate. Here's a more recent study from the European group led by Dr. Del Torre Hernandez. So this was a study that looked at PCI to the left main based on a particular protocol. So they developed this particular protocol. So patients who underwent left main PCI, be it left main alone PCI, so left main disease that didn't involve the distal part of the left main, didn't involve extending into the LAD or circumflex here on the left, whether and as well as a protocol for patients where the left main stent had to extend into the LAD or a bifurcation stent. So there are different parameters. I'll let you read the study yourself to better understand their method. But by and large, they aim for a minimum stent area of more than 90% of the distal reference lumen. And when they were able, or in cases where they followed this particular protocol versus patients who were guided by angiography alone, so in this IVUS Pro versus angio group or comparison, there was a statistically significant reduction in the event rate when you used IVUS according to this particular protocol versus angio alone. They also studied patients who underwent IVUS but not according to this protocol. So IVUS versus angio but not according to the protocol. There was no statistical difference in the outcomes. But if you follow the protocol versus angio, then there was a statistical difference in the protocol. Okay, so I'll just show you one more case. This is a case on the left here. We can see a distal left main bifurcation disease. I did a DK crush PCI on this patient. This is the angiographic final result. I did the final pullbacks of the stent from the circumflex here on the left. So first from the circumflex, so circumflex to left main. We see LAD coming in, so this is within the left main. Stent is well opposed. Stent is quite nicely expanded. A little bit of malapposition here, but I thought that was acceptable. And then I pulled out the IVUS, and here is the pullback from the LAD. So here circumflex comes in. Now we're in the left main, and just focus on the stents. Here's the stent, and then you see at some part here we see a double layer of stent now. And right at the mouth of the stent looks deformed. Right? The stent looks like it's collapsed back into the lumen. So I wasn't careful when I pulled out the IVUS. After imaging the circ to the left main, I pulled out the IVUS, and the guide catheter got sucked in and disrupted the proximal edge of the stent in the left main. I didn't realize it at the point, but so luckily I did a second pullback from the LAD. So I went and did another pot to the left main, and this is the final IVUS now. And we can see that the stent struts are now much better opposed again. But the stent has been shortened, so it's not quite at the ostium anymore. But nonetheless, it was okay. All right, and the final areas were okay, meeting the 5, 6, 7, 8 kind of criteria as described by the Asan medical group. Okay, so I think intravascular imaging post-PCI, we know what the adequate parameters should be, the 5, 6, 7, 8 rule for left main bifurcation PCI. Or aim for at least 90% reference lumen, 90% aim for a minimum stent area, which is more than 90% of the reference lumen area. You got to look for complications such as dissections, osteopositioning, and stent resorption. Just a very quick word about OCT in left main. Can we use OCT in left main, since everything I've spoken about was IVUS. Obviously, we can. One of the limitations of OCT in left main is the fact that we have to engage the guide in order to get good contrast clearance. And sometimes that makes it difficult for us to assess the ostium of the left main, because our guide catheter is engaged in, and the guide catheter itself is opaque or does not allow for light to penetrate through. The way to get around this is to use a guide extension catheter. You can see here, this is within the guide extension catheter already. In this example, I used the Guidezilla from Boston Scientific. And even within the coil, we can see a little bit through the catheter. So this is just a still image to show we are inside the distal 2 millimeters tip of the guide extension, and we can still see beyond it. So this is one potential way you can put a guide extension catheter into the ostium of the left main and still get a good OCT image. What other catheters can we use? We can use the Medtronic telescope. We can use Teleflex guide liner. They all allow us to see through the distal 2 millimeter tip. But the Nipro Guide Plus does not allow this. So if you can see this pullback over here, it suddenly just goes dark because the whole extension catheter is opaque to the light. Okay, so in summary, left main PCI is one subset where we must really minimize mistakes that are preventable. Large randomized controlled trials have proven that imaging improves patient outcomes. So I think, although we don't have randomized controlled trial left main in particular, we should be able to extrapolate this to left main PCI. So there's no excuse not to use imaging in left main PCI. I think if we don't remember any numbers, at least remember some of these. The pre-PCI left main minimum luminal cutoff of 4.8 millimeters square in Asians predicts an FFR of less than 0.8. And post-PCI left main optimization criteria are available. 5, 6, 7, 8 criteria is quite easy to remember. And I think practice makes perfect. Don't be afraid to start using IVUS. A lot of people think that, oh, I don't know how to use IVUS, so I don't want to start using it. But I think it's important to start using IVUS. Practice makes perfect, and it's important to get familiar with imaging. Thank you very much.
Thanks very much, Dr. Chin. I think that's a very comprehensive talk on the use of IVUS in left main PCI. Can I ask Mohammed, what's your view on this? I'm pretty sure you use IVUS for your left main cases, right?
Yeah, thank you, Jonathan. Thank you, John. This is a great presentation, and the first presentation was great to summarizing the data about left main. I think imaging is, if you don't use imaging in every case with left main, you have to use imaging. It's very nice illustrated case where the stent deformation happened with the guide, and that's, I'm sure every one of us had the guide either sucked in or jumped into the stent. So I think using imaging in left main is an essential, and that's also a way of more understanding the anatomy. Sometimes it helps you also in deciding the stent, whether to go with single stent or two stent strategy, the stent position sizing, whether to use calcium modification treatment. I think it's very essential. I would recommend using it in every case. And unfortunately, there's still some people, even in my center, who they think they can get the stent size, which is probably right. With experience, you can get the sizing appropriate, but it's not only about the sizing of the stent, it's about the complication and assessment of the lesion itself. It definitely increased my knowledge using more stenting, and in here I'm using it in every left main case. Definitely, we can't use it in all. It's not reimbursed in Australia, so we try not to use it for every case, but definitely with left main or complex PCI, definitely add another dimension to achieve the best result. And as Dr. Ahn mentioned before, is about performing the best procedure. I think imaging is an essential aspect to perform the best procedure, especially with left main intervention.
Yeah, thanks, Mohammed. I agree. I don't think there's any excuse not to use imaging in left main. It's if there's any one kind of cases that you should use imaging, it's probably left main. And so, Lam Ho, do you have something to say? Lam Ho?
Oh, okay. I think Dr. Qin gave an excellent talk. He had detailedly show us why and how to use imaging guided PCI, and in left main, we fully understand the IFAS and strongly support. For me, maybe 100% I will use IFAS if I do left main PCI. But as you know, in AP region, just like Mohammed said, even in Australia, not every center can have intravascular imaging to guide the PCI. So how to settle this? In the old day, we don't have imaging. There's some two tips and tricks can share if you really can't use IFAS. One is while you do the two-stent left main bifurcation, you do the kissing. Remember to do long overlap kissing. Then your left main stent usually will have a good expansion and safely good expansion. The other tips is to when you do the POC, you try to feel your indicator. If you have more experience, you feel that when your stent match the vessel size, the indicator, the feel will be different. You feel some tension, and then that is the limit of your balloon. And in this way, you really don't have IFAS. This is the way, by your experience and your feel, to make a appropriate size. But this, of course, it needs lots of experience, and it cannot replace IFAS. Finally, IFAS still is the most accurate. But in case you really don't have IFAS, you can practice these two tips and tricks. You better try to feel the interfader not in left main first, and probably in while you're doing outside or doing other procedure, then that can help. Okay.
John, you're muted, John.
Thanks, Lam Ho. I think that's a good suggestion. But I still remember Brian telling me you could probably feel intimal tear with your inflator, and it's probably too late. But yeah, of course, like in situations where you don't really have IVUS, then that's probably one of the only way you can use to assess your stent expansion. So Brian, you have something to tell us?
Brian, you're muted.
Brian, you're muted.
Sorry about that. Thank you. That it was really excellent talk. Thank you so much, and a great overview of the many roles of intravascular imaging in left main PCI. I have a question about how you personally are approaching intermediate left main lesions and using imaging versus physiology to determine significance. So if you tomorrow do an angiogram and somebody's got a 40% mid-left main lesion, are you going to do physiology and imaging, just one or the other? And if it is physiology, is it a resting index or FFR?
I assume the question is directed to me. So personally, personally, I would use FFR. Yeah, if I had a borderline or an intermediate left main lesion and I wasn't sure whether I was going to intervene on it, then I would use FFR first to decide whether or not I was going to intervene. But that's coming from having the luxury of access to both imaging and physiology, and not being limited to one or the other. If I was limited to one or the other, then I would be happy to use IVUS to decide. But because I have the facility of using either one, I would go with FFR first, a hyperemic one rather than IFR. If I do find that I need to do PCI, then I would use some form of imaging, be it IVUS or CT.
Great, thank you. And I actually just had one other general comment, just based on some of the discussion here. We were part of an observational study called Light Lab with Abbott with OCT that was done at about 16 centers across the United States, where for each PCI, somebody was recording data, and based on the angiogram, we would say what we thought the vessel size was, et cetera, and then we'd do the OCT and then record what the actual vessel diameter was. And, people kind of think if you do this all the time, you get better at interpreting the angiogram. And we actually found across the full spectrum of operator experience, people who had just started with OCT, people who had been doing it for many, many years, there was actually no difference in how wrong people were. And in 86% of cases, OCT changed the operator's assessment of the vessel during the course of the PCI, regardless of their experience. And so I think that is important to keep in mind, thinking about whether we are actually training ourselves or not.
I think that's an important point, and a lot of people think that with enough experience, they can replace the use of physiology or imaging indices, but it's not always the case. It's difficult to tell them that they're not right, but yeah.
Thanks very much, Xiang, and thanks very much, Brian, and congratulations, Brian, on your new paper on circuit intervention.
Yeah.
So, just one last comment from Jack.
Yeah, thanks a lot. I just like to chip in to comment about the two lectures. Wonderful lectures from both Brian and Xiang. Learned a lot. Regards to Brian's lecture, I think to put it in context, in Asia, it is not common we have that equipoise type of patient that decides between CABG and PCI. And we're just not talking about patient as well. You're talking about them as equivalent techniques or outcomes, but in Asia, oftentimes you have such varied expertise. Sometimes the CABG results are not what you think as the long-term results. And in some centers, actually PCI outperforms CABG due to just pure expertise, I would say. So in that context, it's actually not apple for apple comparison. And just put it in context again, in Asia, there's a huge percentage of patients who are actually surgical refusers, probably half of them. The other half are truly surgical rejects. That portion is actually much lower than you have in the States. And there's probably a subset of patients that we should not do ad hoc PCI always, take it to an MDT discussion. And oftentimes, maybe the best approach is medical therapy because they are beyond both PCI and CABG. So a question to Brian, because he sort of like glossed over the peri-MI adjudication. I loathe to do any cardiac enzymes post complex PCI because there are always some enzyme leak. And I wonder what is his approach now. I mean, there's a lot of controversy and debate. I also do not find it meaningful to do routine peri-procedural check for cardiac enzymes. And maybe you can give us some pointers about if you're doing a complex PCI, is it necessary to do this adjudication? Thanks, Brian.
Yeah, thank you. No, for this, I think I agree fully with what you're saying, whether just locally at a single hospital or hospital system or regional, globally, there are important differences in expertise, patient preferences, et cetera, that are central to any decision about how to approach that. I totally agree. Yeah, the procedural MI thing is, we could spend 6 weeks talking about this and we'd still come to no resolution. I would say where this is particularly relevant is in trials where you're trying to determine whether somebody had an endpoint of a certain type. In clinical, and so there you can make arguments, whatever. In clinical practice, I see no role for routinely looking for this. If somebody's feeling good after their PCI, I don't know why would you check an enzyme level? For what purpose? So I don't do any of that unless somebody's having an issue. And still there, it's not usually guided by cardiac enzymes. It's my sense of how did the procedure go? Did I know that we jailed a side branch and I was going to see how they're feeling? Did I do imaging so I know there was a good stent result? And if they're having a little swirly chest pain, I don't really care. It's almost, actually, I can't think of a time that I made a decision about whether to go back to the cath lab based on a cardiac biomarker.
Okay, thank you everyone. It's been a great discussion. We're going to move on to the last segment of our program, and I think everybody is looking forward to this part. We have a debate, and I'm going to read to you all the title. Distal left main bifurcation disease. Is it going to be a two-stent strategy for all? For the proposition, I'm glad to present Dr. Richard Chan, who's going to give us his take on that. And Dr. Richard Chan is an interventional cardiologist for Columbia Asia Hospital in Malaysia. And he's a very experienced interventional cardiologist, and he's going to share our insights on the topic with us.
Thank you so much, Jonathan. Let me just share my slides. Oh dear, I can't seem to find it. Hang on for a second. Okay, there you go. I think it's a humongous task for me to cram all this debate and a case presentation under 10 minutes, but I'll try my best to be as concise and as clear as possible. Oh, that's a bit of lag. Okay, hope you guys can see my slides. All right, so what's the debate about? We have been talking about left main bifurcation stenting, dual stent strategy versus provisional stenting. And I want to mention this, that the more popular route taken is the way with the least resistance. And I'm sure many of us agree with this statement. And many operators, especially young practitioners or low volume operators, appear to favor provisional stenting because it's easy, it's less time consuming, and it's backed up by studies of recent evidence to prove its relevance. So I think we should not use all this as an excuse, but let's dive straight into the evidence. And a lot of us have heard about EBC main. Okay, what is this study? It is done in 11 European countries. And it is designed to examine clinical outcomes in patients with distal bifurcation, left main stem lesions undergoing intervention. So they are randomly allocated to either a stepwise layered provisional stent strategy or a systematic dual stenting strategy. Okay, so a layered provisional stent strategy, meaning that they will go as they see. And if, let's say, the site branch is stenos more than 90%, or if the T-miss flow is less than 3, or if there's a type B dissection, then they will proceed with a 2-stent intervention. Okay, so 467 patients were randomized, between half of them to systematic dual stent approach and the other one to provisional stenting. So what are the results? The results show that in the primary endpoint of death, MI and revascularization, there are numerically higher incidence of cases in the systematic approach compared to the provisional stenting approach. Okay, so what about the secondary endpoints? The secondary endpoints consist of death, MI, and revascularization, and both of them shows, or all of them shows, that there is a numerically higher incidence in the systematic dual stent approach, but those are not statistically significant. Okay, so as you can see here, in the provisional stenting, the primary endpoint is 14.7% versus the planned dual stent strategy, which is 17.7%. And the p-value is 0.34, which is not statistically significant. And for TLR, it's 6.1% for provisional stenting versus 9.3% for dual stent strategy. And the p-value is 0.16, which is also not statistically significant. Okay, so let's move on to another study, which is a landmark trial, which was done in 2017, which involves 5 countries, over 26 centers. And the aim of this study is called DK Crush 5, is to determine whether a planned DK Crush 2-stent technique is superior to provisional stenting for patients with a true distal left main bifurcation lesion. So the objective is to investigate a target lesion failure at 3 years. Comparing the two groups, this 482 patients with Medina 111 or Medina 011 were randomized to DK Crush stenting for 2-stent strategy and a provisional stenting. Okay, as we can see here, the target lesion failure in 1 year is 5% for DK Crush and 10.7%, which is statistically significant with a p-value of 0.02 for provisional stenting. And as we look into the breakdown of the primary endpoint, target vessel MI, stent thrombosis, And we can see that the difference is statistically significant. Okay. So the p-value for the primary endpoint is 0.02, and TLR p-value is 0.06, which is not quite there, but it is still significant. So if we want to compare the cases of death, TLR, and stent thrombosis, we can see that the EBC main versus DK crush, the two-stent strategy have got a higher number of patients with death, but it's not statistically significant once again. And for target lesion revascularization as well, DK crush, 3.8% in the DK crush 5 versus a 9.3% in EBC main. And those two, if you look at it, if you compare it, the p-value for the DK crush 5 is 0.06% versus a 0.16% for the EBC main. And of course, there is a statistically significant difference in terms of stent thrombosis. DK crush 5 has got a p-value of 0.02 versus a 0.9 p-value for the EBC main. So all this tells us that in the DK crush 5 trial, the benefit favors a lot to patients who undergo a two-stent strategy with DK crush technique. Okay, so DK crush strategy definitely remains superior to a provisional strategy at 3 years follow-up. And patients with complex lesion defined by the NERS2 or syntax scores appear to benefit more from DK crush than those with less complex lesions. So in summary, DK crush 5 adds to the evidence that an upfront two-stent strategy may be more appropriate in selected patients with complex anatomy, of course, when carried out by more experienced operators. Okay, so I want to talk a bit, since this debate is, for me, is to favor a two-stent strategy. So let's talk a bit of bad things about EBC main. So this study, EBC main, is designed to be a superiority trial and not an inferiority trial. So in other words, it is not a superiority trial, it's actually a field study, okay? And it is an open design. Both operators and patients were aware and could have led to theoretical bias in interpreting clinical outcomes. And the anticipated endpoint rates were actually much higher. Okay, so it's 25% for the dual stent therapy, but versus the real evidence that was only 17.7%. So that could lead to some type 2 error. There is also non-uniformity of procedural steps. There are no POT done for 15% of the cases, which was actually one of the mandated procedural step in both arms. And there's no kissing balloon inflation in 11% of the patients in provisional stent group. And there are no side branch stenting in 5% of the patients of those in the dual stent arm. And of course, the operators who perform the cases for EBC main compared to DK crush are less experienced. In fact, the DK crush 5 trial, only operators who have performed 3 to 5 educated DK crush cases were allowed to enroll patients, but there are no such criteria for EBC main. And I want to mention one of the staringly problems with the EBC main is that only 5% of the dual stent strategy was using a DK crush technique, but majority of them were using a keloid technique. And if we look at the DK crush 3 trial, it is really stated that the DK crush is so much more superior than the keloid. If you look at the primary endpoint, outcome 6.2% versus a keloid, which is 16.3%. So I think there is a big flaw in this EBC main by just not deploying a lot of cases for DK crush technique. And let's look briefly on this definition 2 trial. This is a trial to assess the benefit of two-stent technique compared to a provisional stent but it's not really focusing on left main. But however, in this trial, 28% of patients were left main disease and left main lesions, and 78% of the cases were used and deploying a DK crush technique. And as you can see here, the target lesion failure for provisional stenting was 11.4% versus a 2-stent, which is only 6.1%, and it's definitely statistically significant for this. So all this actually points towards a favor more towards a 2-strand strategy compared to a provisional stent strategy. Okay, I'm not going to explain in detail about the steps of DK crush, but I'm going to do so in the next case that I'm going to present. So what are the advantages of doing a DK crush? So it assures the coverage of the side branch ostium, and it prevents loss of side branch, definitely. And it can be used if the side as a main branch or side branch are different in sizes, or which one is bigger. It can be used in different angles. And the good thing about this DK crush technique is that the wire is always kept in the main brush. We never take out that main brush wire. So, and of course, it's mentioned in DK crush 3 that DK crush is superior to keloid. And what are the disadvantages of DK crush? It's definitely more steps, so therefore more complex, more time consuming, and there would be some difficulty in rewiring the lesions 2 times through the struts. So what is success without sacrifice, right? So, okay, let's look into this case. This is a real case, 51-year-old Chinese man. He's an active smoker, diabetes, and he has got 3-vessel disease with left main stem disease. CABG was done. He had 2 grafts, Lima to LAD and in SVG to the OM. The small caliber vessel, I'm not sure whether it was a Lima or SVG, was just written in the OT notes. So it was only 1.5 millimeters. So ideally, usually the surgeons will look for a vessel which is at least a 2 millimeter. So it is no surprise that he actually came back 2 months later for an AVR STEMI. And when we did an echo for him, his EF dropped from 60% to 32%. So this was his angio. And as you can see, there is a Medina 111, very tight distal left main, very tight osteal LAD. And the circumflex is almost CTO, subtotal stenosis there. And this is the RCA, which is a co-dominant RCA with a CTO with bridging collectors from the branches. And this is a graph study, and as you can see, the Lima is really tiny, okay, and it is occluded. And we could not find the SVG to the OM, perhaps occluded as well. So we gave him the option of CABG versus a high-risk PCI. And of course, just only 2 months that he had the surgery, he was not keen at all to redo the CABG, and his syntax score was 38. So anyway, he opted for high-risk PCI. So what did we do? We put in an IABP, and we engaged, we used the EBU 7 French. So this was the IVUS finding. The circumflex, the distal circumflex was a 3 millimeter vessel, and the proximal was about 3.5 to 3.8. And this is the LAD. The proximal part is a 4.6, and the left main is a 5 to 5.5 vessel size. So we pre-dilated the circ with multiple balloons. And we stented the distal circ with a 2.538 stent, and overlapping with a stent jutting out about 2 millimeter into the left main. And we crushed the stent with the balloon that was ready in the LAD. So this is where it's crushing it. And we did a first KBI with a 3 millimeter balloon and a 4 millimeter balloon. So we proceeded with stenting the mid to distal LAD, and from the ostium to the LAD. So we did a pot with a 4.5 balloon and a KBI. And we pot again with a 5 millimeter balloon at 14 atmosphere. So this was the final results. So post-IVUS, we can see that the stents were very well expanded and well opposed. And we were happy with the results. And on follow-up, IABP was removed and patient was discharged after 2 days. And 12 months when he came to follow-up, he remained well and asymptomatic. So in summary, for complex left main bifurcations, DK crush approach is currently the best proven technique. And the mean syntax score in EBC main was 23, only compared to a 31 in DK crush 5. So imaging is utmost necessary for lesion recognition and especially to look at stent expansion. And of course, I want to end with this, that we need to study each case and tailor it accordingly. Trials are only there to aid us. And when we're on the battleground, common sense and strategic thinking and your gut feelings rule. And with that, thank you so much.
Thanks very much, Richard. I think that's a very good illustration of the benefit of doing two stents bifurcation in distal left main here. So we'll leave the Q&A session after we have the other speaker, Dr. Carmen Ho, who would tell us the other side of the story tonight. Dr. Carmen Ho is cardiologist at Tuen Mun Hospital. She graduated from the Chinese University of Hong Kong and then went on to complete her medical training and cardiology fellowship in Tuen Mun Hospital. And she's currently one of the senior cardiologists in the hospital. Her research interest would includes heart failure, and she's also a very experienced PCI operator. So Carmen, I'll leave to you.
Thank you very much for giving me a chance to be here to talk about the distal left main bifurcation. After an excellent talk from Dr. Chen, because we are sharing the similar control trials, but we are looking at the different ways. So my point today is to support the one stent approach in the distal left main bifurcation. So for the professional approach, and that is more simple, involve fewer stents. So you translate into less contrast use and less radiation, but you need to maybe more side branch compromise and more target lesion failure. So for the past few years, there is endless debate about whether we should use professional or a two-stent approach. And I borrowed this slide from the European Bifurcation Club. We all know that for the complexity of the procedure isn't a linear curve to the clinical outcomes. For those very complex procedure, we may have more poor outcomes. So it's very important to find not too simple, not too complex, but we are achieving the good clinical outcomes at the top of the curve here. So as a cardiologist, so I share two cases first. We have recent cases who is a 75-year-old lady who has renal failure and or peritoneal dialysis and was admitted for non-STEMI. So this is her coronary angiogram. It shows the left main was quite okay. Also has stenosis, but seems not significant. But the mid LD has a critical stenosis, and so we did an IFIS, which shows a circumferential calcification at proximal LAD, and there's no landing zone at the LAD. So we decided to stand up to the left main, and we wired the cert, and we did IFIS, which shows no significant lesion at the osteo cert. And because of the calcification, we did the shock wave to the LAD and decided for the professional stenting. So we send the LAD, we put a left main stent, and we do the pot. And this is the final angiogram, which shows quite a good result, that the cert ostium was quite okay with the professional approach. But however, she was admitted 4 months later because of non-STEMI. And this is her angiogram, which shows a critical osteo stenosis. and also severe ISL at the LAD stent. And indeed, we did an IFS which shows heavy calcification. Actually, you can appreciate the calcium chunk here. And we did shockwave, and we decided to use the reverse crush approach. We stand left side, crush it with a balloon, and do a kissing balloon angioplasty, port it, and this is the final result, which is excellent. And then I have a second case, who is an 83-year-old gentleman. He had diabetes, hypertension, hyperlipidemia, admitted for acute pulmonary edema and cardiogenic shock. Current angiogram show left main and triple vessel disease. And then because of the old age and multiple comorbidities, he is not a bypass candidate. And therefore we proceed to PCI under impeller support. And this is his coronary angiogram, which shows a critical distal left main stenosis. LAD was totally occluded. So I didn't show the RCA angiogram here, but there's retrograde back to the LAD. So we wire the start and predilate the left main, and the LAD flow improve. And we decided to do a two-stent approach with the mini crush technique that we usually use in the center. So we stand the start first, and stand the LAD and left main. Actually, I hope that you can appreciate that actually our stent was quite well expanded with minimal overlap, minimal metal overlap over the left main bifurcations, and we did the usual way using a kissing balloon inflation. So this is the final result, which is very good compared to the initial coronary angiogram. But however, he had a recurrence angina 1 year later. And this is what we're seeing. There's a critical left main and osteocyte ISL. And we did IFS, which shows there is under expansion of the stent. And what we do is we do angioplasty, kissing balloon angioplasty, and followed by kissing DEB. Because we don't want to put another stent, put another metal layer to the left main. So this is the final result. Still some under expansion due to calcium, but I think that this is the best we can do. So So I have two cases, which the first case we used the proficient approach, and was remitted for non-STEMI, and the side branch, the circumflex, have a critical stenosis, and we managed with a reverse crush. And for the second case, we use upfront two-stent approach for a patient remitted for angina and have a severe distal left main and circumflex stenosis, and we manage with a kissing DEB. So are they better than each other for both approach? Seems they can get a problem sometimes. So we have a lot of observational studies in the past, like this BPK left mains registry, which showed double stenting was associated with a higher long-term risk of MACE. This Korean registry shows that two-stent strategy have a higher risk of target lesion failure, target lesion revascularization, and a one-stent approach is preferred. Another study from Korea, which shows that professional and the two-stent have a similar adjusted risk of target lesion failure at 3 years. And another Excel study showed that for the one-stent approach, there is a lower composite endpoint of death, MI or stroke, driven by difference in the cardiovascular death and MI, and also the ischemia-driven revascularization was lower in the professional group. So why are we having so heterogeneous results? Those studies I mentioned before, just observational studies, not really true. Left main bifurcation, they involve a lot of other, not only Medina 11 or 011. There's no standardized professional technique, and also the two-stent technique. And there's no routine IFS use, which we learned that IFS is very important for doing the left main bifurcation. So we talk about the same study again, because I think for this debate, these are the main randomized control trial that we have nowadays to talk about the professional versus two-stent approach. I think we all have enough information from Dr. Richard talk on the EBC main and also the DK Crush 5. So just a very quick run through of these two studies again. They include the true left main bifurcations. For the professional strategy in EBC main, basically they they recommend to do kissing balloon angioplasty for all cases with professional approach. And for two-stand, they can use whatever technique the operators like a culotte, DK, mini crush, T or tap. So actually for the professional group, 22% need side branch stenting, mainly due to the dissection of residual stenosis, and most operators use the culotte or tap. And for the two-stand approach, most operators use the culotte or tap, but only 5% use the DK crush. And these are the results which has been talked about by Richard already, which shows there is no significant difference between this endpoint, although numerically there's a higher chance of revascularization in this two-stand group. And indeed for both strategy, we have a similar angina improvement, which is most important because we are treating the patients rather than angiogram. So the conclusion of study is that for the stepwise professional approach, there's a fewer MACE, but that's not statistically significant. So they suggest that the default should be a stepwise professional approach for the left-wing bifurcation. So how about the DK crush? I think Dr. Chen also have a very good talk on it. And professional strategy, unlike in the DBC main, they suggest you can do KBI if there is a residual stenosis of the side branch more than 75% with dissection, TMA3 flow. And if there is a suboptimal result after KBI, you stand it. And for the two-stand, it's only DK crush. And actually in the professional group, they have 47% of patients who need a side branch stenting. And for those who need side branch stenting, up to 2/3 of them have a complex left-wing lesions. And indeed, this is the red line signify the professional group, which have higher target lesion failure and also more target vessel myocardial infarction. And also, they also find that the professional group have more stent thrombosis. But when we look at the data of stent thrombosis, which 6 cases happen in the professional group, they all have side branch stenting and have a longer side branch lesion length and wider distal bifurcation angle. And actually, most of them have an incomplete revascularization. So what the conclusion of the study is that using a DK crush have a lower and also target lesion revascularization rate, and is actually driven by fewer stent thrombosis when compared to the professional group. So, but why the results so conflicting? Because they're quite different. In terms of the lesion complexity, BC Ming have a syntax score of 23, had a shorter side branch lesion length. And the crossover two-stand is actually higher in the DK crush 5 group. And also the criteria that they stand the side branch is also different. And also for the two-stand strategy, the DBC may use more culotte, while DK crush all use the DK crush technique. And the primary endpoint is also a bit different. So actually, we know that the complexity of the lesion is also very important. So actually for the DK crush 5 group, they also divided them to the simple or complex lesion by using the definitions of the side branch lesion length. If it's more than 10 millimeter, diameter stenosis more than 70%, and plus any two of following, like the multiple bifurcation, thrombus, the vessel diameter, lesion length, bifurcation too wide, too narrow, to decide whether the patient is simple or complex. And we can that actually professional approach doesn't have a significant difference with the DK crush if we're dealing with simple lesion. And recently, and the meta-analysis, which include these two randomized control trial and also 10 observation studies in before, which shows that there is a similar rate of MACE, mortality, CV mortality, MI, stent thrombosis between the two groups, while the meta-analysis showed that there is an increase in target lesion revascularization in the two-stand group when compared to the professional group. So my conclusion is, actually, I think for the left-wing bifurcation is really individualized approach. I think the lesion complexity is very important, including the lesion length, stenosis, bifurcation angle, and calcification. And I don't think they are actually mutually exclusive. I think for simple lesions, professional stenting have a very good result. But for those complex lesions, I think we should consider often two stent approach, and DK crush actually have a very nice result. So for the KISS principle, shall we keep it simple, swift, and safe? But I think for left-wing bifurcation, we should keep it selective, smart, and safe to select the best patient for the professional or two-stent approach, and do it smartly and safely. I think this is the best way to deal with a left-wing bifurcation. So this is the end of my presentation. Thank you very much.
Thanks very much, Carmen. It's a nice talk, and what a conclusion, saying it's probably right on both sides. So Dr. Ahn, do you have anything to share with us?
Thank you very much, both of you. Very nice presentation. So I'd like to say that the study population of EBC main and DK crush may be different. As Dr. Ho said, I think DK crush cohort may have a more complex advanced left main bifurcation disease because the side branch stenting length is a lot longer in DK crush cohort than the EBC main. So we have to know that even in the randomized trial to compare the provisional stenting and the two stenting, in EBC main 20% and DK crush 47% of patients in provisional group finally require the side branch stenting. So I think the advanced complex left main bifurcation simple crossover stenting is not that simple in a certain percentage. So to look at the DK crush, 47% of simple crossover stenting finally received the side branch stenting. As Dr. Ho mentioned, this group made a higher rate of periprocedural MI and late TLR and stent thrombosis in provisional group. So I think learning to stenting is important to improve the simple crossover stenting when it is not feasible during the procedure. And I think I fully agree with Dr. Ho's the last slide. Two stenting and one stenting is not the competitive, but the complementary. According to the circumflex ostial lesion, please wisely select the simple stenting or complex two stenting. But I think the final issue we needed to be further evaluated that how to objectively assess the left main bifurcation. We need a further evaluation of this regard. Thank you.
Thanks very much, Dr. Ahn. Yeah, I agree. That's a very insightful comment. We probably should individualize each case and each lesion to decide our approach here. Dr. Shiono, are you a fan of provisional or two-stent?
Thank you. Yes, thank you very much for your nice presentation about the two strategy for left main bifurcation. I totally agree with you. But I think the honest idea we usually have is just to make it simple for the left main bifurcation. If we can keep it simple, we are happy. But what we have to know is that if we face the complex left main lesion, we need to be prepared for the complex PCI, particularly using the DK crash. Maybe this is my opinion. Maybe the physiology might make it simple, even though if it looks complex. I mean, if the Medina 111 lesion might be the Medina 100 or 101, 101. From the physiological point of view. So I think that using the intravascular imaging and also the physiology might change the strategy. That's my opinion. Thank you.
Thanks, Dr. Shiono. So Brian, your thoughts?
Yeah, thanks so much. I thought those two talks were really excellent and gave a great overview of the area. It does strike me that there's a lot of evidence at this point on an area that I think we give a lot of thought to technically, but in the end, do we do we really think that one stent is going to make people live or die? You know, I think we care a lot as technical operators, but I think a lot of the evidence shows that for most people, most of the time, it's pretty similar. And that, as I think both talks said, this really comes down to our assessment as operators, our gut feeling, and what do we think is right in this particular circumstance. In general, let's try to keep it simple, but if there's something really bad that might happen, then go with an upfront two-stent approach. And, you know, aside from the evidence, I think the DK crush approach, you don't ever give up a wire on a non-stented vessel. You can use it in essentially any anatomy. You know, just why not? So, you know, I think I agree with both speakers, you know, try to keep it simple. And if you're going to stent them both, then do it well. Do a DK crush and use imaging and do a good job.
Yeah, so Brian, I know you're a fan of DK crush, but in the rare circumstances you do a provisional stenting in the left main, like if after stenting the LAD, the left main, the cert appears pinched, what would you do, or would you do anything?
Yeah, it's a great question. We talk about this a lot. So in the EBC compare trial, they did in the stepped provisional approach, the protocoled procedure was to recross into the jailed branch and dilate the stent struts. I don't do that routinely. I don't see a reason to manipulate a stent that you've just placed in the left main. Very often, even if the ostium was completely healthy angiographically or by imaging as well of the jailed branch, there's going to be some degree of angiographic pinching. And so I think the EBC main compare gave criteria, so visible dissection, reduced flow, et cetera. But beyond that, if there is significant pinching, I do assess it physiologically. I don't think imaging is wrong, though most of the time you will have to dilate the stent struts to get an imaging catheter down, whereas a physiology wire you can get across without having to manipulate the stent. So if I stent left main LAD and the circ is pinched, I'll generally do physiology just to document it. And then obviously if it's abnormal, then fine, you convert it into usually a culotte. And if it's normal, then great, you're done.
Yeah, I think that makes sense too. That's probably what I would do too. Like sending in a physiology wire is probably quite straightforward for compared with like putting in an IVIS. As you said, we probably need to do something to the stent, which kind of defeats the purpose. Like that's what you try to avoid here, right? So, Mohammed, what's your thought here?
Yeah, thank you. I think it's great sum and great presentations and all the talk. I have a question here, and that's in general to you might answer me or with your thoughts. If you go provisional stenting, and whether it's impinged or not, do you usually end up with kissing and pot? Because we know that data from, I think from the China or Korean data was showed there's no difference basically whether you recross and pot or just ended up with just single stent with pot and no kiss and no recross and kiss, whether you just pot and that's it at the end. And I know the European usually prefer to do the recross, kiss and pot. What's the general thinking here? When you go provisional mainly, this is mainly on a provisional.
Yeah, are you asking us that the final casing balloon after the simple crossover stenting?
Yeah, like when you go provisional and everything is fine, do you usually go recross, kiss and pot, or you just pot and that's it?
Yeah, so far there is no evidence that the final casing balloon improved the patient outcomes. Our some medical center registered data show that the final casing balloon after simple crossover stenting did not improve the patient outcome, rather increased some clinical event numerically twofold higher in the final casing balloon application after simple crossover, maybe due to some damage to the left main stenting. So I think the left main to LAD stent optimization is more important than the circumflex in case of simple crossover stenting. So don't do anything further in case of simple cross stenting if side branch ostium looks fine. If you do more, I fully agree with Brian's opinion. The measured FFR is negative. Don't do more. So based on our small registry data show that if circumflex ostium looks fine after simple crossover stenting, the risk of FFR below the 0.80 is only 7%. So even though there is some pinched, angiograpically pinched side range ostium in the circumflex ostium, before do something, please measure the FFR. That is my opinion.
Jack, you have something to say?
Yeah, I wonder whether I can just tell you what my thoughts are on all these trials. I think it's not a technique, it's a philosophy behind the left main bifurcation. I actually don't quite support the philosophy of a provisional for bifurcation left main. I think actually you have to prejudge the technique. So I think upfront you do have to have a prejudging of whether this is a truly complex and therefore upfront true stent rather than a provisional stepwise. I understand the philosophy behind the provisional approach to try to keep it simple, and there's no loss to say that you can do a subsequent bailout either intra-procedure or even subsequently. That's their philosophy. But I think based on the data, I think you do have to prejudge a lesion. You have great tools of both physiology and imaging. You can prejudge, and therefore to Carmen, you can keep it selective upfront and then keep it simple after. So you do have to decide. That's my view of the left main bifurcation subset. And I do support that trend. And I also support the fact that if you already prejudge that the osteocirc is not terribly diseased, I never even want to check it, even with FFR, where I just pop and get out. If you think you're worried, there's really something there. Most times, don't look at it again. And I will follow the EBC main philosophy then. If there's issue, I can always come back later. There's no harm loss. The only subset I'm very wary of, which is what Carmen said, is the end-stage renal failure subset. In that subset, even if the disease complexity is high, the recurrence rate in the osteocirc location, even with a beautifully done procedure, is very high in the osteocirc location. So in that subgroup, I don't think I quite have a handle of what is the best solution for durability, which I don't think there is. So I tend to keep it simple for that particular subset, even if it's complex. Thanks a lot.
Thanks, Jack, for that very insightful and practical comment. I think the end-stage renal failure group is a group that we all dread and worry about. Now I'm going to just close with a summary of some of the learning pointers that we had over the course of the last almost 2 hours. From Brian's lecture, we learned that CABG and PCI in the left main disease is fairly comparable, but in the higher risk subset, higher syntax scores, CABG may fare better. CABG has more strokes, but PCI has more revascularizations as well as more more MIs. From Chiang's lecture, we learned that pre-procedure imaging is very important. If anything, a cutoff of 6, anything more than 6 in the left main, we may be able to defer PCI. And also it's very important in optimizing PCI results, the 5, 6, 7, 8 rule. And from the debate, I just want to give a quick summary. I think, as all of us who are practitioners in the field, I think it's important to get ourselves familiar with 1 or 2 strategies for left main, 2 strategies stenting. So, if it's DK crush for you, be really good at DK crush. If it's a DK culotte or culotte, really be done good at it so that, you do it day in, day out. This is your preferred technique. So that's for a 2-stent strategy. If you go provisional, you also need to have a backup, meaning that you need to get yourself familiar with 1 strategy to bail you out should you need the 2-stent strategy after the provisional fails. And I remember, in a live case of one of these gurus in PCI was saying that, he doesn't understand what the fuss about the left main stenting is about. He says, why are people worried? Like the left main is a big vessel. most times you get no problems. It's not like some small distal vessel where you struggle to get stents through. And I think there's some wisdom in that words. Obviously, we know that the area of myocardium subtended is huge. But in general, I think we should not let our fear govern some of our decisions as well. So be good, practice more on one strategy, and after you're familiar with something, you want to go explore something else, by all means. With that, I would like to close this session. I'd like to thank all our panelists, speakers, as well as faculty. It's been a great discussion. I myself have learned loads of it, and I hope to see you all at our third session coming up in a couple of months. And for all those of you, the audience who have stayed here on a Saturday evening in Asia, thanks so much for spending your Saturday evening with us. Thank you.
Thank you.
Thank you. Bye-bye. Great session, guys.
Bye. Thank you.
Thank you.
Bye. Thank you.
Thank you.